Welcome back to part two of our session with Jake, our first chat with Jake, where we were talking about what makes a good therapist. We ended up chatting for a very long time. So today we're really excited to bring you part two of our chat. So we are just going to get straight into it, and I'm going to bring back the recording from last week. I want to come back to the imaging chat that I put a little pin in it before, and I want to unpin it and just unravel it. So
This is a fun one. It's one of our favorite things. I love talking about imaging.
yeah, I was gonna say imaging. So what we're gonna do is we're gonna chat about bad treatments, I guess. And so I'm gonna put imaging a little bit under this bracket because imaging's not bad inherently, but sometimes the way imaging's prescribed is, well, a lot of them, unfortunately.
And just so everybody knows, imaging is X-rays, MRIs, or a CAT scan or a CT scan. So anything that like a modality to examine the inside of your body. So that's what we're referring to as imaging. It's any one of those.
Yeah, also going to include bone scans, which are less likely, and also ultrasound assessment. So there's a difference
Diagnostic
between
ultrasound.
diagnostic ultrasound versus treatment ultrasound. So just clarifying that. Good point to bring up there straight away. So I'm kind of putting this a little bit under the bracket of it can be a bad treatment thing for therapists to provide. And there's a big it depends banner on that topic. So whilst the treatment itself, so the test itself, isn't inherently bad, there are some things that can be associated with it, and it comes down to the narrative. So I'm going to leave it to you to explain a little bit more
It
about
comes down to the narrative. So there's a time and a place to do a scan of someone's body, whether it be an X-ray and MRI, because they're incredibly powerful and helpful diagnostic tools when it comes to more severe pathology, things like cancers, fractures, infections, autoimmune diseases, things of that nature, incredibly helpful. But if you have no suspect of one of those things going on, when a patient is not presenting with any of the signs or symptoms of serious pathology, there's almost nothing that you can learn from them. But therapists in the business world have learned that images are a very powerful marketing tool because people trust them implicitly. Which means that if a chiropractor, for instance, not going to rag on chiropractors too much, but if a chiropractor takes an x-ray of your spine, if you have no pain whatsoever, but they take an x-ray and tell you you've got lots of problems, you're going to implicitly trust the x-ray because we don't know better, right? So there's this it's a manipulative marketing tactic that a lot of therapists use to scare people into doing more therapy than is necessary. And that's a very big statement, but it's absolutely true, is that a kind of aggressive and predatory therapists, let's just say that, predatory therapists and business schemes use imaging as a marketing fear tactic. And its only purpose is to scare you. It doesn't matter what's going on in your body. They're going to find something on that x-ray or MRI that looks scary and then convince you that you're broken and tell you they're the only ones that can fix it. So a bunch of those buzzwords that they use are like spinal misalignment. They'll tell you that your spine is out of alignment or your hips are uneven. They'll find something on the x-ray. They'll say you have degenerative disc disease, which is a real thing, but very often misdiagnosed by a chiropractor or a therapist. They're just trying to scare you. Like some degenerative changes can be normal and non-symptomatic, but they'll find them and tell you that they are abnormal and symptomatic. So it's like they're misdiagnosing things that can be used as just as a fear tactic. So basically, unless there is direct suspicion of a serious pathology, your specialist should not be just taking x-rays on everybody or taking MRIs on everybody. There needs to be a reason for it. So one thing that you can do is just, if someone recommends you to take a scan, ask why. And if they have a really good reason, they're like, well, we actually suspect that you fractured something, or we suspect that there might be a pathology going on because you have this as symptoms that make us suspect it. If they say that, absolutely do it. But if they're just taking scans on everybody who walks in the door, I can guarantee that there's not a good reason behind that. They're trying to get your money. They're trying to sell you something.
if they're including it as a part of their marketing. So if they're like, this appointment with so and so asterisk includes x-rays, that should be a flag. Like that should not be a part of marketing. It's like a doctor being like, come see me, plus of like including blood tests. Like blood tests are not required of every patient that walks in through the door with the doctor. So same with imaging. So it should not be included in marketing for a practitioner.
Well, and you said that there's nothing wrong with these images, with one little exception, is that there is absolute research to show that people who take unnecessary MRIs end up in more pain than people who don't take MRIs. And the leading belief behind that is that when you take an MRI, it can drastically increase your sense of despair about your condition, your fear, and your anxiety about your future. Because if you take an MRI and they falsely diagnose you with something like a disc hernia or degeneration, they use one of those buzzwords, it makes you feel very broken and hopeless. And a lot of people leave the MRI reading feeling completely lost because they think, I have two options. I either end up in a wheelchair or I pay thousands of dollars for this treatment. The therapists usually frame it like that. Like, those are your two options. You're either going to end up in a wheelchair or you have to pay me a ton of money to fix you. And so there is, or three options is what?
Third option, surgery.
Or surgery, my gosh. Yeah. So it's like people, there is a known, proven, like researched phenomena of people who do end up worse after an MRI, but it has nothing to do with the actual MRI. It's about the narrative that they create about the MRI.
So let's bring it back to, because we very briefly earlier talked about slipped discs and how we don't use that term, because a lot of patients are like, but my MRI or my, this or that shows that I've got a slipped disc. So first of all, I just want to clarify that term. We don't slip discs. Discs don't just slide out. That doesn't happen. Discs can bulge, they can prolapse, and they can herniate. And that's the correct terminology when it comes to that. However, a certain percentage of those are actually considered normal and are asymptomatic. And this is the problem when it comes to imaging. So far people are like, they're probably listening, but they are like, I still don't see the problem with imaging. Sure, it might make me catastrophize more, but I still don't understand it if it shows me what's going wrong. There's an assumption there that taking an image of, your spine or any joint in your body is actually pointing to your pain. And quite often, more often than not, when you take an image of your spine and it shows multiple disc bulges or some degenerative changes, they are actually considered normal. So there are some people out there that, sure, they may have herniated a disc and it's actually compressing the nerve root and it may be contributing to the pain, but there are also a bunch of people out there who have herniated a disc and it's compressing the nerve root and it's not causing any pain. And
not only a bunch of people, most people.
Most people. There's been
most people have these changes in their spine without pain. So it's like there's not a known correlative or causative relationship between these things in a general population of people. So people have back pain and they have a bulging disc, but those are two completely different things.
Yeah. So it's our job as therapists to actually determine whether, one, you're suitable for imaging, and two, whether your imaging findings are actually correlating with your symptoms. Because a lot of the time we get MRI findings and they're actually normal. And so they look abnormal based on the results, but they're actually not causing your symptoms. And so a lot of time when we get an MRI, I have to spend a lot of time preparing my patient to actually pre-warn them that it will probably show up a whole bunch of stuff. And it's about figuring out whether that stuff is appropriately relevant or not. Like if I get an MRI that comes back, and happens very rarely, that shows there's nothing wrong, I am legitimately shocked. And there was a brilliant study on this that I want to.
Never happens.
Oh no, it never happens. There was maybe once. I reckon once in the last 10 years have I seen an MRI come back completely normal.
And that person probably had pain.
And they had pain, absolutely, they had pain. And when I say normal, I mean no findings. There's been lots of patients where it comes back with findings, but it's normal. So there's this great study where they took at least 1,000 people and they were asymptomatic, never had back pain before in their life, didn't have it at the time of that particular study, and they got all these MRIs. And they basically correlated the findings of the MRI. So they got radiographers to report, radiologists to report, radiographers to image, and they correlated the findings of this asymptomatic group. And then they put the findings down per age group. So they had I think teenagers, 20s, 30s, 40s, every decade basically. And what they found was that as early as your 20s, we start to show age-related changes within our insides. And the easiest way to explain it is that a disc bulge in a certain population, like the 20s and 30s, may be considered normal. In fact, is usually considered normal. It's about us, finding out whether that's actually contributing to your symptoms or not. And most of the time it isn't. Like 99% of the time, it isn't. Sometimes we have an acute ligament sprain that's associated with it that might be causing some temporary irritation, usually settles down within 4 to 6 weeks. If instead you get an MRI with that 4 to 6 weeks, you see you've got a disc bulge, that 4 to 6 weeks suddenly becomes very sensitized and blown out to 8 to 12 weeks, maybe even longer. So not getting early imaging is actually usually quite helpful unless we suspect a serious pathology. So that's like the younger population. What we found is that when we hit 50s, 60s, 70s, 80s, so I'm kind of grouping up 40 years of people together. Sorry to those who are watching that are, in their 50s, not to group you with the 80-year-olds. But as we go through our decades, those changes certainly increase quite significantly. There were people in that study, I thought this was fascinating. There was a couple of people in that study that actually showed what we deem a medical emergency. So they actually had full disc herniation pushing on what we call the corticospinal cord. And so that would be deemed potentially a medical emergency because they would usually be associated with loss of sensation and strength in your legs, as well as potentially bowel or bladder changes. They had none of those. They were asymptomatic and they still had what would be deemed emergency surgery based on that MRI finding.
So basically you can take an MRI and see some really scary, terrible looking things, but the patient is completely capable of going about their everyday life, which means that there's not a lot of conclusions you can base on just a scan. You have to combine it with a really good physical examination, like analyzing what the patient actually looks like and presents like, and their pain and medical history. But like just the x-ray or just the MRI tells you very little. Unless something's really sinister, there's really not much that you can learn besides just like, yeah, they're a person who's alive. Just like you can't really tell the health of my body by looking at one patch of my skin. Like it might have a scar, it might have a little burn mark, it might have a callus, but what does that actually tell you about my health overall?
Nothing.
Like not much. You have to talk to me. You have to get to know me and get to know my symptoms in my life to actually know my health. So like that's how we should be approaching those medical images. And we know like there's a big institution around taking images and using it as a sales tactic. So that's kind of what we're talking about here, is like that, just as a red flag for you guys to look out for. Like if you're at someone, they're using these images to scare you into something, it's probably predatory and it probably has nothing to do with your health.
A good therapist, like you said, they'll look at images if required, but they will determine whether it matches the assessment. The thing that should actually carry the most weight in terms of, caring for you is the therapist's assessment, and the MRI image or any other form of imaging may assist in determining the treatment plan. I always say to therapists when I'm mentoring, why are you sending this person for an MRI or for an X-ray or whatnot? Will that change that person's outcome? So I never will send someone for an image unless it will change their treatment outcome. So if I'm concerned that there may be a hidden fracture and it's potentially being missed, that would change their treatment outcome. So I'll send them for that imaging. So I'm not saying that we don't send for imaging. I certainly send for imaging, but it needs to be appropriate imaging. Now, if that image came back, there was no fracture, it showed X, Y, and Z, all these little things are going on, they don't bother me so much because they don't necessarily relate to the assessment findings. I'm then going to treat them per the assessment findings. We as therapists want to be treating the patient, not the image. And that is something that hopefully is drilled into us worldwide now, but there's still a lot of therapists out there who don't. So I think that's definitely important to bring up. I also want
to, unfortunately, there's a financial incentive to misinterpret images. And that's just the sad reality of it. There's a big financial incentive to use it as a fear tactic.
And radiologists make bank. Not going to lie, they are probably one of the best paid healthcare professionals out there. They make bank on images, so they push for imaging. Sorry to radiologists out there who are, hopefully you
love you. You're very smart.
we agree that we're not going to deny that you're not good at your job. You're great at your job, but there is a lot of research out there that shows.
But it's also very rarely the radiologist they're just reading the film. They're just doing their thing. It's the person who's recommending the imaging that's usually suspect. Like that's the one you should question. The person reading the film, this is actually an interesting point. If you get an MRI, you're going to get a report of that MRI. The person who wrote that report knows nothing about you intentionally. Like they know a very brief description of your history, but they really don't know much about your present. They'll be like, oh yeah, this person has a low back pain. That's all they know. They don't know anything else about your presentation. So their job is to look at this film that is of somebody they don't know and just list everything that sticks out to them as being a little bit different. It's not their job to diagnose you with anything crazy. They're just coming up with a list of things that look different than the usual. And then it's the primary care physician or your therapist who's supposed to interpret them correctly. So when you get that list of information from your MRI, that's not a list of everything wrong with you. That's a misinterpretation that a bunch of people has, that they get their MRI report and they think it's just a long list of everything wrong with, like, it's just a long list of everything that's bad. That's not what it is at all. It's just like, it's like if you look at your teeth and then like, oh yeah, this tooth is a little bit above this one. That's just an observation, right? That's not a diagnosis. It's just, so that's what a radiologist is really doing, is that they're looking at your MRI and observing it. And people should not be interpreting that as just a list of pathology or disease.
Bad things. Yeah. I think the other thing I want to mention is that a really nice analogy that a lot of therapists these days use is as we go through our life, we start to show changes in our skin. And I think what you said before in terms of scars and so forth, but we might start to experience globally some more wrinkles will appear, sunspots, beauty spots, etc. All of those things will change as we go through life. That's what's happening inside our body too. So a lot of the things that are being picked up by the radiologist, are actually those normal changes that we experience as we go through life. Like if you x-ray,
and it's good for them to notice them. Like it's okay to list them. Like, yeah, you've got some of these changes, like age-related changes going on in your body. It's good to know that, but we should interpret it through the lens of normality.
And there are definitely, so not to, we're very one-sided here in terms of imaging. There are definitely images that there are situations when imaging is very appropriate, like I said before, and there are certain points where I have seen or sent a patient for imaging, or the doctor has sent a patient for imaging. I look at it, I go based on my assessment, and I go, yes, that marries up. I first of all go, was that an appropriate referral? Like, did that actually help me? Like most of the time I've got the diagnosis by myself. I don't really need the imaging. Or does this confirm what my suspicion was, and does it confirm that we might need further intervention? So that's where I'm like, imaging's not terrible, but
yeah, like if you're in a car accident, you have neck pain, go to the clinic, absolutely get an image just to make sure it's not fractured. But that's the process it is. Like you're gonna say, hey, why are we getting an image? The doctor's like, you're just in an accident, we suspect a fracture. Like there's a clear defined reason why you want to take the image. But if you go to the doctor and like, yeah, I haven't had any recent traumas, I don't have any weird pains, I just feel a little bit like, ugh. And they're like, let's take an x-ray. And you should be asking why. It shouldn't just be like, let's look, see what's there. That's not a good enough reason.
My pet peeve is, I've had shoulder pain for 6 months, so I'm just going to take an image, but I've never seen a therapist.
It's going to distract you. It's going to create a false narrative, and it's going to be a distraction from what you actually need in the long run.
Exactly. Because we can talk about imaging all day. Let's move on to some other passive therapy treatment techniques that are utilized, and we'll touch on them really quickly. Let's talk about, you talked about electrotherapy agents before. So we're talking about things like a TENS machine, which is basically a machine that you can put on your skin, and it's supposed to, there's two options for it. You can use it to contract a muscle, and I think that can be quite helpful for a certain population when they're trying to work on motor control and building up some strength in a certain situation. But most of the time, TENS is used as a pain relieving tool. So they put these pads on, they basically, it sounds weird, they're almost like semi-electrocuting themselves. They're putting electricity through the muscle.
100%, that's what it is. It's an electrocution.
It kind of is, to like a very mild degree. They send like a signal to the area, and it's like a weird tingling sensation, and it's supposed to block a pain pathway. There was all these theories about it. If your therapist is providing TENS to you, there is significant evidence out there that TENS is a placebo, if that at all. So there is actually evidence guidelines in Australia that says that TENS should not be used for low back pain. And the reason why that came out is there was a time, very much so in the 90s, but early 2000s as well. I hope there was still, like, I heard news recently of one in my area that was still doing it, but they're almost retired. So hopefully they, sounds horrible, but hopefully they retire sooner rather than later. But there's definitely was an age of therapists, a group of therapists at a certain point where they got taught in university that TENS is effective for everything. And what they would do is see patients have 4 or 5 on the go and basically put a TENS on that one, on that one, on that one. And they would just basically go around treating multiple patients with the exact same treatment. Besides the fact that TENS is not effective for pain relief, that is unethical on so many points. my only thing that I want to talk about here is that if you were doing it to yourself, if you were putting tens in yourself, you're in a machine, hey, it's placebo, it's not going to hurt you. But if
And it costs like $20. Like you can buy a TENS unit for like $20, or you could go to a physical therapist and have them do it for you for $40 a session.
more than that, trust me. It does say in Australia, you're looking at a minimum of 80 plus more. So, and that's for like a
For them to use a $20 machine that can be used a million times. So it's like, it doesn't make any sense.
It makes zero sense. That's the exact same with interferential. Interferential went through a big phase at one point. A lot of people don't know what that is, but it kind of is very similar. It does like a pumping movement of the muscle. The other one is ultrasound as well. So there's been a lot of evidence, and this has all happened over the last 10 or so years, probably even longer, 20 years, that shows that these treatment modalities, so ultrasound treatment, not diagnostic ultrasound, they are basically no more than placebo, with the exception that there is the use of ultrasound treatment for mastitis. It works a little bit differently. So anyone out there who is postpartum and experiencing difficulty with breastfeeding and they're noticing their ducts are getting blocked, please go see a physiotherapist, or women's health physio or pelvic health physio. And there are definitely some musculoskeletal physios that treat mastitis with ultrasound. That is the only thing that ultrasound has evidence for. If you're seeing your physiotherapist, you're paying them money and they're performing ultrasound on you in your sessions, I would really suggest looking into why this is not an appropriate treatment modality to be doing these
because they can bill you for it.
For it.
It's just to bill you more money.
It's doing nothing. It's there's actually
it's like what there's just, it comes down to like, what's a good use of your time? Like if you have 30 minutes with a patient and you want to sit there doing like a little electric therapy for 25 of those minutes, like you're paying for it. And listen, we don't want to invalidate. If someone feels good doing one of these therapies, that's amazing. And you're completely justified in wanting that for yourself. But it shouldn't be the crutch that a therapist use to create long-term results. So that's what we're talking about. We don't want to invalidate people's experience, and we don't want to say that it's like something you should never do. Placebo effect is great. And if it's something that helps you feel great, there's 100% need for that in your life. If you feel good doing it, go for it. But it's like time versus benefit with a therapist that you're paying for.
Yeah.
Right? Like if you're paying for a therapist, you should be getting as much benefit as possible. You're not going to get as much benefit as possible if you're just doing those feel good things.
Yeah. And like I said, it's placebo, but placebo still is an effect. So no, a lot of
it still can be helpful. Like I kind of like the way TENS feels. So I have a $20 machine that every once in a while I'll put like on my back or something. And I don't know, it's kind of fun and I'm fine with that, but I'm not like looking to it to solve my life. So
yeah, and I think that's important. And like we utilize TENS with labor, and that's like, a completely different thing. But so there is a point, I believe, for some of these modalities. I'm just like, don't seek, as a therapist, please don't provide this as your primary point of healthcare to your patients. Like it should not be, ideally it should not show up in any of your appointments as a treatment modality. But if you are going to keep it to the absolute bare minimum and figure out why you're actually doing that, there's probably been 1 or 2 patients in the last 5 years that I've actually justified the use of a TENS machine for, and it was certainly really appropriate for those people. So that's fine. But it should not be a recipe that you're slapping it on every patient and they're walking in and out every 10 minutes. Like that's wrong. That's unethical. But for any
and the narrative that you create around it should not be like magic bullet, this is going to heal you. Yeah. So even if you do use it, great, but create a good narrative.
Yeah, spot on. And then the other thing I wanted to talk about was the use of other passive therapies like injectables. And so this is a real common one with the shoulder. And this is probably a little bit more my experience, probably, and definitely in Australia, therapists here.
Yeah, I'll just comment that I'm not entirely sure about Australia, but in the United States, in most of the world, I would say, don't talk to your chiropractor about injections. that's not within our scope of practice, and I don't like ever recommend or not recommend it from my point of view, because it's really not my point of say. In Australia, Simone, for instance, has extensive experience working with this stuff, so I default to her knowledge on this one for sure.
All right. I was going to say, I know that certainly in America, therapists in general are almost not allowed to have an opinion anyway on injectables. So like physios shouldn't have really, like they're allowed to have their own personal opinion.
Physios here in South America, it's malpractice to talk about it. So it's like, it's not part of it's like a different world. So So yeah, it just depends on what part of your world, like what part of the world you're in, whether it's like a physio topic or a GP topic or general practitioner. I am of the opinion that in this side of the world, so anyone in the Americas, if you want to talk about getting an injection or any type of medication, that should be a conversation you have with your general practitioner, not with your physio or your chiropractor.
Yeah, and that's so fair. And I was going to say, and I know in like countries like Germany is a really good example of this. Physios are not primary health care practitioners there, which blows my mind a bit. But you have to see your doctor first to get a referral to see your physio. So it goes through a really weird process, I believe. Well, that's last time I chatted to a German patient about it. That was still the process. So I imagine it hasn't changed since. So I think that, different countries. So please, for anyone internationally, watch this with a grain of salt and apply it to your medical system with a grain of salt. But certainly different countries have different rules. And I would say that in most countries worldwide, most therapists aren't aware of use of injectables. Oh no, they're aware of the use of injectables, but they aren't necessarily trained in understanding when it's appropriate versus not. So whilst, chiropractors, physios in the US will be aware of injectables, they know exactly what they do and so forth, they are not allowed to form an opinion on it to the patient, whereas I can. So I'm going to talk about this topic for a little bit. So there's so many different types of injections out there. You've got things like hydrodilatations, where they will inject liquid into the shoulder for a frozen shoulder. You've got things like a steroid injection, which is basically a corticosteroid, and that will be a pain relieving injection. There will be PRP, protein-rich plasma, which jokingly a lot of doctors who are against it in Australia have called it profit-rich plasma because it makes you a lot of bank. And it's been shown to basically do nothing. And it's basically taking your blood from a donor site, from your elbow or so forth, and then injecting it, and then injecting it into another part of your body, which needs more blood flow apparently. And then there's a whole bunch of different other substances like Synvisc, etc., which they thought would help create cartilage for osteoarthritic knees and so forth. So there's heaps and heaps of injections. You can also have like radio frequency denervation, so you can actually burn nerves with injectables and so forth. So there's a whole bunch of different stuff out there. So in Australia, we have a tiered physiotherapy system, so to speak, where you graduate from your undergraduate degree or your postgraduate degree and you are an entry-level physio. From there, you can go on and do further study. Most of the profession, unfortunately, don't, which is sad, and it's changing. It's definitely shifted a lot towards the direction of them doing further study in the last 10 years, but a lot don't. Those who go on and do further study, they can go on and do a postgraduate certificate and follow it on with a master's. And sometimes they skip the postgrad, they can get straight into the master's. In Australia, having done a master's degree on top of an entry-level degree allows you to be a titled physiotherapist. And that's through our association. And having that title comes with a lot of extra knowledge, which is about this sort of information about injections and so forth. Whilst the entry-level physios will have a really good basic understanding about it, they may not understand exactly when it should be used and when it shouldn't be used. So they'll quite often also refer to the doctor or the specialist at this point. They might not feel so comfortable. Sometimes people don't go on and do their masters, but they just gain significant experience over their years. So there might be a physio in Australia that's been out for 10, 15 years, and they just have a really good understanding of injections through exposure and their own individual learning. So that's also important to know. But generally speaking, in Australia, if you're seeing a master's or an APA titled physiotherapist or above, because there is another level of specialization, if you're seeing one of those therapists, they should have a really good understanding as to whether you're suitable for an injection or not. So if you're coming to see myself and you're like, should I just get an injection? I'll be able to tell you whether it's appropriate or not at that point and whether we should refer to your doctor. I can't refer you for an injection, but I have that ability to go, look, this is appropriate versus no, this is never going to be appropriate for you. A lot of the times patients, again, coming back to the narrative, tend to go for the passive style treatments because they want that quick fix option. In certain situations, a corticosteroid injection may provide a temporary band-aid relief. In other situations, it may be the only thing that you need. And so a really good therapist and doctor and specialist in Australia will actually be able to go, this is probably going to eliminate 90% of your pain and it will actually knock it out. That is very rare. That's like 1% of patients who actually go for those injections. Do they have that sort of immediate and effective long-term pain relief? Most of the others get a temporary pain relief, and they should be doing therapy in the meantime. The harsh reality, and we've seen research since come out, show that those who actually get those Band-Aid relief injections every couple of months from their doctor don't actually do their therapy, and they actually end up worse in the long term. So
The Band-Aid.
it is a Band-Aid, but the problem is they just keep on getting the Band-Aid. And there's real detrimental effects of having repeated corticosteroid injections. So first of all, if you're diabetic, you should not be getting steroid injections. Speak to your healthcare practitioner, but generally speaking, you should not be getting should not be getting steroid injections. And if you've had surgery, you should also, like recent surgery, you should not be having steroid injections within a certain period of time. So there are some contraindications about steroid injections and some significant precautions. But for everyone else who's had steroid injections, I would never let a patient have more than a couple within a year. And I certainly have a threshold of like how many they're allowed to have total. And the reason is that a steroid injection can actually degenerate a joint or tendon quicker. And I don't use that term lightly because I really don't like the word degenerate, but it has been shown that to cause significant long-term effects and short-term effects by using a steroid incorrectly or inappropriately in the wrong area, or even appropriately, but just repeated use of steroid. Our muscle fibers, our tendon fibers, they don't like it, and it can actually break them down. So a once-off injection might be okay. 2 times might be fine. 3 times might even be fine. But when we're getting past that 3rd time, it's really like this is not helping you. Like we need to really...
Because at the end of the day, in most cases, it's just another passive therapy. And it's like people turn to it as a magic bullet, but as we've established, that just doesn't exist. So it's just another passive therapy that has its place, it has its time. But if it's being used consistently as the only means of healing or treatment, it's probably not going to work.
Yeah. So I would really encourage that before you seek injectable or imaging, see your therapist first. Whilst that therapist may or may not be equipped to tell you whether a steroid injection is appropriate or not for you, at least try conservative therapy first before going for the next level of intervention.
Or active therapy. Conservative active therapy.
Yes, absolutely. It would kind of be like going, I have a toothache, and reaching straight for morphine. It's kind of maybe not.
Or surgery. Or reaching straight for like dentures.
Exactly. Yeah, exactly. Reach for the Panadol first. And then from there, if it's more than that, we can increase what intervention we need.
And like start brushing your teeth too. You know? Like, form a healthy habit. Like do something.
Exactly. So I think that there's a lot that can be done before. Actually, it's not that I think, I know there's a lot that needs to be done before you go for injectable. And so, yeah, if you're in Australia, seek the advice of a titled physiotherapist or a specialist physiotherapist. Specialist goes on to do way more study. That's an insane amount of study that they do. But seek the advice of a healthcare professional that has expertise in this area. And I'm not, I'm never going to say a bad thing about GPs because they do terrible job. They do a wonderful job. I just said a bad thing tonight. They do a
my pearl, like no.
No, they do a wonderful job in terms of gatekeeping, and they all have their own special areas of interest. They do a really brilliant job, and they're under the pump no matter what country you're in. They're slammed regardless. I've dealt a lot with Australian-based GPs, so again, I don't know about many international-based GPs. I know a few, but my experience is mostly Australian GPs, and they're wonderful here. But I view them as gatekeepers, with their own areas of special interest that they might be like have a little bit of extra knowledge in. So like a GP might be like a skin-based GP, and they go and like have a little bit of extra knowledge in that, or they might just have a real special interest in gastrointestinal or like family planning. Like, you know, they might have their own area. But very, very few GPs out there have a special interest in musculoskeletal or sports-based care. And so very few of them actually understand the information that we do as physios, osteos, and chiros. And that's okay. That's why when you see a GP, they will often do one of 4 things. They'll educate and provide you advice, which is wonderful. And a part of that may be exercise. In my ideal world, that's what happens every time at a GP. That would be beautiful. The next thing they can do is provide you with medication or referral for injectables. So sometimes we need oral medication sometimes we don't. Sometimes we need injectables, and that's fine. What I don't like is when you see a GP and they send you straight for injectable. That's my bit of a
without any other education or recommendation. Yeah. It's just like, it's the same thing as a therapist who only does passive therapy.
Exactly.
Like, no different.
Again, I'm very lucky where I've worked in the past. I work with sports doctors and I've worked with GPs, and before they send for injectables, they quite often will send to us first, get our opinion, and then we'll refer back if we thought an injectable was appropriate, and so forth. Or they'll call me up, and I loved that. I loved getting a call from the GP next door, and them going, "Hey Simone, seeing so and so, and I just wanted your opinion on this. I know you haven't seen them before, but this is how they're presenting. What are your thoughts?" And I'd be like, "Yeah, that's so appropriate based on what you're telling me. You know what, send them over. I'll have a quick look at them. Let me just do a quick assessment." And I'll write, call them back, be like, "Nah, not today. We'll get them in for a proper thorough assessment and see what we can do." So that collaborative approach is really, really important. That doesn't happen very often in Australia, but I was very lucky. So I know that's unfortunately not the norm. So we've got educated advice, meds or injections, image referral, which again should not be your first point of care unless there is serious pathology suspected, and then referral. So in the ideal world, the GP refers to the appropriate healthcare professional, particularly if they don't feel like their advice and education is enough alone. So quite often they'll provide advice and education, and then they should pretty much set up the referral for the healthcare professional that has the knowledge. And that's how it should work. Like I said, they're the gatekeepers. They're not supposed to know everything. The idea is they are there to help create the plan and oversee the medical treatment, and we're working underneath their plan and their care. But as healthcare,
it's like they're the ones who confirm that it is a musculoskeletal issue. It's like if you have back pain, they're the ones that should figure out whether that back pain is cancer or it's a musculoskeletal, other type of musculoskeletal issue, So it's like they have to make those distinctions. And if it's a musculoskeletal issue, then they have to figure out whether it's going to be medication or referral, hopefully referral, where they can get a little bit more time with the therapist. So yeah, it's a very necessary gatekeeping, and it kind of rules out like that dangerous stuff,
Absolutely. Yeah. So I think that when we collaborate correctly and effectively as a healthcare team and profession, things work brilliantly. And I think it's really important to not hate on other professions. I think that's really, really important. We don't want to be going, "Oh, I wish that damn GP again sent straight for it." Like, that's just not helpful. If you, as a therapist, if you're like, "Oh, but the issue is that they keep on doing this and they just don't refer to me, they go straight to point 2 and point 3 and they don't actually refer," take the time to spend with your GP at your local GPs and educate them. So if you, as a therapist, for any therapists watching, are finding you feel frustrated with the fact that then you're not getting the referrals when they should be getting referred straight to you, and you're seeing them 6 months post surgery and they should never have gone to surgery, go to your GP and spend time educating. Build that connection. That's how you're going to ensure that your patients are being seen by you before they end up in surgery unnecessarily. And trust me, there has been so many patients I've seen over the years that have ended up in surgery unnecessarily. One that was a shocker a year ago. So she came in, ended up with a hip replacement. Their pain was never coming from their hip to start with, it was coming from their lower back.
What if we do a whole nother video on surgeries?
Oh, let's not do that.
That's a whole nother topic.
We said we weren't going to go overtime. Like I guaranteed, we are overtime. And that's fine. That's okay. We will we like to chat, and we like to provide lots of education advice out there. So I think this is a great forum to be able to do it. So I'm hoping that those of you who are watching are enjoying and really learning some key points in terms of what good therapy and what bad therapy looks like. So let's recap. I think, yeah, exactly. So good therapy. Basically, the healthcare practitioner listens, takes the time to actually listen and value what you're saying, and validates what you're feeling. I think that's important. We didn't really talk about that initially, but that's key. They spend the time with you in that process. They provide a really thorough assessment, medical exam, medical history taking session, and they provide an emphasis on active therapy. And whether that's in the first session or whether that's a couple of sessions in, it's okay. So sometimes you might initially need more hands-on, but they should be talking to you about an active plan and getting you out of that situation.
Create independence.
Yes. So yes, exactly. They should be creating independence. they should be addressing multiple things. They should be addressing, your belief system, your understanding of what's actually going on, as well as, providing you the tools to then manage that. They will not oversell you appointments. So a good therapist will ensure that you are being seen appropriately. You're not being underseen either. So that's a bad therapist is also underseeing their patients. So it's about trying to ensure that they're being seen in a timely fashion for what that person needs. The worst thing is someone not progressing, and then as a result, they then regress with their treatment. And then a good therapist will know how to progress you all the way back to your activities and what you need to be able to do. I've seen many a time a bad therapist get you halfway and then go, well, that was all I kind
Or they just get you out of pain. Like they stop once the pain's gone, then there's no rehabilitation back to your lifestyle. So with pole dancers, we've got first, we're gonna rehabilitate you out of the pain, and then we have to recondition you to go back to pole dance so that you're doing it safely. So like we don't just stop once the pain's gone.
We need to make sure that you are well taken care of, because otherwise pain's going to come back. You go back to doing the thing that was hurting you in the first place, and you don't have the capacity to handle it. Pretty much guarantee you're going to relapse. Yeah. Right. So other things that was good therapists, kind of halfway towards bad therapists now. Other things that bad therapists will look like are short-term visits, or short, quick visits that are done on repeated frequency, like high frequency. So whether it's once a week or 3 times a week, and they just don't, there's no end in sight. They'll, bad therapists will lock you into a contract. They'll put that real heavy emphasis on passive therapy. They don't really spend the time to talk you through what's actually happening. They don't provide that education. They don't provide that active therapy. And then they might not be bad therapists, but bad therapy would be unnecessarily ordering imaging, or sending for injectables or other passive treatment modalities, or utilizing TENS ultrasound unnecessarily, etc. Have I missed anything there, Jake?
I mean, that's a really good summary, I think.
Yeah, no, I think that's pretty much everything. So I think, look, you've heard today from both a physio and a chiropractor our views as to what good therapy looks like and what bad therapy looks like, and we hope that gives you lots of information as to what is happening for you potentially individually, now or in the future, in the past, what may have happened, and so giving you that awareness and education so that you can then pass on to your those around you. So if you see someone else going through what we've explained today as a bad therapist, then hopefully you can raise that as a flag with them and say, look, I think you might need a second opinion for this, because it doesn't seem like getting anywhere with your therapy. So I think that's important, but also understanding that not all healthcare professionals are the same. So there are good physios out there. There are some terrible physios out there. So you haven't tried physiotherapy if you've tried one physiotherapist. There are some great chiropractors out there, and there are some terrible chiropractors out there. You haven't tried chiropractic therapy because you've seen one person. It's like saying you've tried a barber and you've gone to one barber, and so it didn't work for you, and then then you're gonna go see
even like despite our titles, Simone and myself work almost identically. So it's like if you are following the correct evidence, like the scientific literature, there really shouldn't be that much of a difference. And the bigger the difference there is, the less likely they are to help you.
Yeah, that's a really good point. Yeah. So in terms of help, so the Pole Physio team are obviously here to help you. You should hopefully have a pretty good understanding about how we work after today's session. I hope so anyway. I hope we've given a really thorough understanding of how we work and how we wish in the idealistic world every therapist would work, and maybe with their own individual flair, but we kind of wish that this is how the healthcare community as a whole, certainly from the private practice point of view, worked. But if anyone out there does need help, Jake is now seeing online patients through the Pole Physio as an affiliate member. So we're very excited to have Jake as a part of, as an affiliate to the Pole Physio. And Jake is able to see US-based polars and aerialists, which is very exciting. Unfortunately, that's one thing I'm not able to do due to my my legal indemnity insurance and requirements, as well as US law.
International law is real weird.
It's real weird, y'all. I said that with an American accent. No, I didn't. That was terrible. Sorry.
But we're making it work. We're making it work.
Maybe I just want to be an American. Maybe that's it. So anyway,
No, you shouldn't.
There you go. We got the two there. So I unfortunately can't treat you, but Jake certainly can. So I would encourage, and Jake has a better time zone for most people on that side of the world out there. So for any international pole dancers, European pole dancers, South American, North American, Canadian, anyone out that side of the world versus, you know, Australia, Asia, Europe, not Europe, sorry, Australia, Asia, New Zealand, my side of the world. Those on that half, you're going to be better off seeing Jake in terms of time zone from that point of view, but certainly I can treat anyone worldwide except for US pole dancers, and Jake can see everyone worldwide, so he's a lucky duck. He can see Australian pole dancers as well, and whatnot. So certainly if you're interested in booking an online appointment with Jake and myself, we are very, very happy to help you with your pain. And
even if it's just a second opinion.
Yeah, even if it's just a second opinion. If you're like, I just need a once-off appointment, that's completely fine. If you start off thinking you need a once-off appointment and then you realize that you're like, oh no, I need to see you, that's also fine. We're very flexible and we can adapt.
I have a patient right now who I see her once every like 3 months, and she's going to another therapist to do her like rehabilitation because that's what works better for her. I'm just here to help her with the pole specifics. So it's like, I don't need, like with her, we in our initial consultation, we determined that the therapy that she was in was really good. So she was already with a therapist that was helping her rehabilitate her from her problem. So there's no point in me interfering with that. She's already in good hands with that. We just need to get some more pole specific stuff. So it's like, we do a lot where we work with other therapists as well, just with the pole details, because there is a lot of good therapists out there. And if you're already with one, that's great. Maybe you just need some more pole information.
Exactly. Spot on. And we're very happy to collaborate and work with your therapist. So that's the other thing to know, is that we love referring to people and working alongside other therapists. So it's not that we're going head to head and both having differing opinions. We like to work as a collaborative team. Anyway, so if anyone wants to see Jake or myself, you are very welcome to book. I'm not taking new patients until March, I believe, at this point, but Jake has appointments available, you know, this week. So you're certainly able to book into Jake. And the booking system is through our website, www.thepolephysio.com. Click on the book online button and it will give you all the info you need to be able to book Jake or myself. And Danielle as well is able to take patients, who's also recently joined us for the pole physio team. Danielle's similar to myself. She's an Australian-based physio, so she is able to treat worldwide except for US patients as well. So all three of us are available. We're at your disposal. Yes, disposal. Said that correct. And I was going to say, whilst we can't provide passive treatment online, I can assure you that we can provide effective active therapy that can provide you with immediate pain relief. And I think that's a real special tool for therapists to be able to have, which is to not use their hands but use their brains to be able to get the same degree of pain relief through active treatment. So yeah,
brains are cool. We should use them more.
As healthcare professionals, absolutely.
You'd think it would be straightforward. You'd think that would be a given, but
you think so, but anyway, we're going to leave it there. Thank you so much for joining us for this wonderful journey. We appreciate you watching. We hope that you all have a wonderful rest of your day and take care of your bodies. Bye.
bye.
And thanks, Jake. Thanks, Jake, for joining.
Of course, anytime.
Just so you
We're good. We're good.
Thanks, everyone. Bye.